Welcome all to Raaonline. So today we'll discuss on geriatric trauma. Why this topic? Understand, by 2050, almost half of the world's population will live in countries where at least 20% of population is older than 60 years. And aging is the most significant social transformation of the 21st century. Our current era has witnessed that people live longer and will have access to high quality healthcare system. And moreover, with more amount of elderly age group population, our era is increasingly mobile and active, so there is a risk of serious injuries. And this injuries is now the 5th leading cause of death in elderly population. That's why you need to know about geriatric population and geriatric trauma. So look at this graph. So this is for men and this is for women. So people who have this kind of premorbid conditions, if they have a 3+ condition, the predicted increased mortality rate is going to be very high. See, this violet color is 3+, and red is 1 to 2, and 0 is this. And the predicted increased mortality is very high if the patient is going to have 3 or more than 3 comorbidities or pre-existing medical condition, which is almost same for the woman, but overall they have decreased risk of mortality. Effects of aging and impact of pre-existing conditions. Understand what exactly means aging is that they have declining cellular function, eventually leading to organ failure, and itself it's a part of aging. And the patients have impaired adaptive and hemostatic mechanisms. The skin might be very loose, and so that even a small IV line or a ABG can cause significant hematoma, right? So this condition is called as a decreased physiological reserve. A minimal amount of hypoxia or a transient hypoxia can cause severe multi-organ dysfunction. A transient shock can cause severe multi-organ dysfunctions, or a minimal blood leak or minimal loss of blood itself can put the patient for severe shock, because the reflex sympathetic mechanism may not be completely functional in these kind of patients, right? So, and this all leads to devastating results in elderly patients than the young. In a recent study, investigators identified 5 pre-existing conditions that appeared to influence the outcome in trauma patients: cirrhosis, coagulopathy, chronic obstructive pulmonary disease, ischemic heart disease, and diabetes mellitus. Patients with one or more of these conditions were nearly 2 times more likely to die than those without this kind of pre-existing conditions. Okay, so whenever you see patients who are elderly, you need to ask for each and every premorbid conditions. What is the most common mechanism of injury? It's a fall, motor vehicle crash, burns, and penetrating injuries. Falls. The risk of falling increases with age, and falls are the most common mechanism of fatal injury in elderly population, including the traumatic brain injury. Understand that 1/2 of elderly patients suffering a hip fracture after a fall will no longer be able to live independently at all. So it's going to affect them chronically. What are the risk factors for falls? One is the advanced age, physical impairments like they have osteoarthritis of the joints, where which they will not be able to walk properly. History of previous falls, so they have pain over the joints, or medication use like sleeping pills or any beta blockers where the reflexes are going to be very less, or premorbid condition like dementia, unsteady gait, and visual, cognitive, and neurological impairments also. Environmental factors like loose rugs, poor lighting, or slippery or uneven surfaces will make the patient more slippery and fall. Motor vehicle crashes. Usually if you see elderly people who drive and end up with an accident, you will see this kind of setup, like they usually drive only fewer miles and they drive only in familiar roads. They usually have only lower speed driving, and they drive during the day because of the daylight is available. And they usually drive on the weekends to see their loved ones, and they typically involve other vehicles because all the stationary things they will be aware of. But if there is a sudden new vehicle which is crossing them, the reflex mechanism is going to be very low. That's the slower reactionary time. They have a larger blind spot and limited cervical mobility to look in the all areas, and decreased hearing for any horn sound, and the cognitive impairment. Additionally, medical problems such as myocardial infarction, stroke, dysarrhythmias can happen during driving, and this can end up with a collision. Burn injuries. Increases risk of burns because of decreased reactionary times even when the patient has some scald injuries or burn injuries. To identify it as a burn injury and to run fast, it's going to take a lot of time. Impaired hearing vision and inability to escape the burning structure itself, because they will be difficult to pull out things, push out objects and come out of the burning structure itself. Spilled hot liquids on the leg, which in a younger patient may re-epithelialize due to adequate number of hair follicles, will result in full thickness burn in older patient with paucity of follicles. So these are the effects of aging on organ systems and implication for care. In cardiac, usually the cardiac function will be declining because the EF declines, the ejection fraction can decline, the patient can have diastolic cardiac failure, the systemic vascular resistance, the pulmonary arterial hypertension, all these can go high, right? So basically the cardiac reserve is going to be very less. Moreover, the cardiac myocardium itself will have decreased sensitivity to catecholamines, and the overall cardiac myomass, the myocyte mass will be less. The coronary vessels can go for atherosclerosis, and overall because of all these things there will be increased afterload, that is the pressure against which the LV, the left ventricle, has to pump is going to be high. Moreover, the patient can have something like a pacemaker or a fixed cardiac output, or the patient can have a fixed heart rate because of beta blockers or PCI or any stenting. All these things can potentially cause decreased cardiac reserve. So implication for care: lack of classic response to hypovolemia, right? When the patient have hypovolemia, usually they'll have tachycardia. But if your patient is on beta blockers or a patient is on pacemaker, the heart rate may not increase. The patients have risk of cardiac ischemia because already the coronary vasculature would have gone for minimal stenosis. More stenosis during this